Good morning, Joel.
Hey, Anupam, how are you?
Hey, Rakesh. Good morning. How are you doing?
Good, good.
Yeah, I just wanted to make sure. Is my screen showing or?
Yes, it is. Yeah.
Okay. Okay. Maybe I'll do it this way. How you been doing?
Good. Busy like everyone else.
You been in touch with Mark Gladwin at all? How is he doing?
He's doing fine. I saw him. He gave the seminar to the Sickle Cell Center here a few weeks ago.
Oh,
So I saw him then, but I think
I
he's
reached out to him to get help for a nomination for somebody for ASCI, and he was very gracious. So he's always that way. So
good.
So Dr. Agarwal, I just
Hey,
saw
Adam.
your
Hey,
morning.
morning. How are you doing?
Good. I just saw your article. I made the joke that it was March Kidney Month. I actually didn't realize that was today.
Yeah.
Was that on purpose?
Yeah. Actually, today is World Kidney Day,
Yep.
and I didn't realize when we scheduled this.
Okay.
We actually have our annual AKI PKD symposium today
Okay.
with Brad Yoder, and we normally have it on World Kidney Day. So I have one slide just to acknowledge that
Okay,
to the group. So
nice.
yeah, good timing. And then you
Yeah.
had,
Well, thanks again.
you had Zarju last week, so
Yep.
good overdose of kidney to your pathology group. So
That was good though. Thank you again.
no, not at all. Thank you.
Good morning, Dr. Agua.
Hey, Yabin, good morning. How are you doing?
Good, good. Thank
Good.
you. Because
Yeah.
yeah, I just heard you said happened to be the kidney day.
That's right. Yeah. World Kidney Day today. So
Yeah, that's wonderful. Looks like people are coming. Normally, it's always the last 2 minutes. That's the good thing about Zoom, right?
Absolutely. My talk's going to be about 40 minutes or so there'll be time for discussion and so on. So
yeah, that's perfect.
Yeah, it's hard for people to sit through for a whole hour, just Morning, George.
Having a hard time logging in from the computer, so the registration is so strict. How you doing?
Good. How are you doing, George?
Good. Still have a couple of minutes.
Gene, good morning.
Good morning.
Hey, Bruce.
Good morning,
How are
George.
you doing?
I'm pretty much well vaccinated.
Morning, Bruce.
That's good.
Anupam,
How are you doing? Haven't seen you in a while. So
been in hiding.
yeah.
No such luck. VPN is not working. It's not showing the participants for me, but I'm sure, yeah, there are plenty. We'll give them 1 more minute. Okay, let's go ahead if you're ready, Dr. Agrawal. So good morning, everyone. It gives me a great pleasure to introduce our lecturer and our grand round today, Dr. Anupam Agarwal. Clearly does not need an introduction to this group, but I know some people are logging from the outside too. So it's a pleasure to introduce my colleague and what I consider a friend, Anupam, who's the director of the Division of Nephrology and the Executive Vice Dean of our School of Medicine at UAB. He also served as a director of the UAB UCSD O'Brien Center for Acute Kidney Injury Research, and he's the immediate past president of the American Society of Nephrology. He just rotated off that post last year in the 2020. Dr. Agrawal is pretty much involved in all 3 areas of our mission, very actively so, I would say. He's continued to teach at the medical school, medical students, house staff and internal medicine and fellows, and he's received outstanding teaching awards from the Department of Medicine at the University of Florida, as well as UAB for his teaching activity. He's a very well-funded NIH investigators with funding also from the Department of Veteran Affairs, studying the mechanism of the topic of his lecture today, which is acute kidney injury. Very well published, over 170 original manuscript and almost additional 50 invited reviews and book chapters, all many in prestigious journal. His work and research and excellence has been recognized by receiving awards such as the Max Cooper Awards for Excellence in Research and the Thomas Andreoli Professorship in Nephrology. Many more to list. For the sake of brevity, I will just mention he is an active speaker on the national and international scene, and has given many prestigious lectureships, including the Craig Teacher lectureship and Mats Wallström lectureships, among others. So it's a pleasure to have Anupam today, Dr. Agarwal, to talk to us about what's new in acute kidney injury. Thank you, Anupam.
Thank you, George. Really appreciate that very kind introduction, and Adam for the invitation to speak to your group. I'll just share my slides. Can you all see my slides? Just make it a screenshot, maybe better. Is this better?
Yes, perfect. Thank you.
Great. So in the next 40 minutes or so, I wanted to share with you, what's new in this field of acute kidney injury, and it's really timely given the current pandemic that we are in, and I'll show you some of that data, why that is the case. So these are my disclosures, nothing of relevance to my present talk today. I wanted to remind everybody that today actually is World Kidney Day. This started about 12 years ago, and the theme for today, World Kidney Day, is living well with kidney disease, and the entire month actually is World Kidney Month. There are over 850 million people worldwide that have kidney disease, and in the US alone, 37 million Americans, so almost 11% of the US population has kidney disease, and in the Southeast, it is a huge issue as well. So again, thank you for the opportunity. You had a speaker last week as well that was speaking on the kidney topic. So I appreciate you all giving us the plug-in for World Kidney Month and in World Kidney Day today in particular. So acute kidney injury is really on the rise and a huge growing threat. So if you have acute kidney injury and you're hospitalized, it increases the length of stay by almost 4 days. The healthcare utilization goes from 5 to 24 billion. So if you're admitted to the hospital, you're in the critical care unit, you have AKI, you can just see 5 times more healthcare costs. And if you have dialysis, that increases the cost even more per hospitalization, about 4-fold, from $11,000 per patient per hospitalization, it goes to $42,000. So significant burden in terms of healthcare costs. More importantly, if you see the death rate, and shown here on the slide, if you combine death rate from prostate, breast cancer, heart failure, diabetes, if you have acute kidney injury, the mortality is more than combined from these 4 other conditions. So you can just imagine how significant the burden of acute kidney injury is for today. So a little bit of historical perspective. Acute kidney injury was previously described as acute renal failure. And this was by Dr. Bywaters from the UK following the London bombings, in World War II, when a lot of people were trapped under the rubble of buildings and so on, and had their muscles, completely crushed, and they had rhabdomyolysis, hemolysis, high potassium levels, and they all died. And at autopsy, Dr. Bywaters found that the kidneys were completely congested and loaded, with hemoglobin, myoglobin, and so on. And he said that these patients were dying out of potassium poisoning because their potassium levels were really high. That was really the first description of acute renal failure. And over the years, the National Kidney Foundation has tried to make the terms we use more friendly to patients, rather than using Latin words like renal and hepatic and so on. We're trying to use more friendly terms, and it was decided to make it acute kidney injury to reflect the broad spectrum of what this disease incorporates. So in most ICD-9 and ICD-10, we refer to this as acute kidney injury. When this first transition occurred, in the early 2000s, people were saying, well, this is trauma to the kidney. So that's really not the case. This is non-traumatic, injury, and that's termed as acute kidney injury. And a group called the KDIGO classified acute kidney injury as stage 1, where you have a 50 to 99% increase in your creatinine from your baseline. And if it goes from 100 to 200%, it's stage 2, and more than 200% rise in your creatinine is stage 3. So this is just a broad definition of acute kidney injury that we use in the clinical setting in the hospital. And there are also urine output criteria, because you can see here it takes 24 hours to 7 days for this change to occur in the creatinine. But you want to make a diagnosis of acute kidney injury in real time, and the urine output really helps. So if somebody makes less than 0.5 ml per kilo body weight per hour for more than 6 hours, very likely that they have acute kidney injury stage 1, and then less than 5 in more than 12 hours, or less than 0.3 ml or anuria, that is stage 3. So this just broadly helps define, and this is the currently accepted definition and staging for acute kidney injury. We all know we are hopefully coming out of this pandemic, and this is just data from last night that I got from the website, daily new cases. We are just hopefully coming out of this third wave, and the daily deaths you can see as well. And this has been a huge, this pandemic has clearly impacted, not just our healthcare folks, but throughout the world with the number of cases that you see. And I know the Department of Pathology has taken a lead role with Dr. Neto, Dr. Sixto Leal, and several others in really leading the charge and trying to contain through testing and other innovative mechanisms on trying to control the disease, not only for our region in Alabama, but actually throughout the nation and throughout the world. So really impressive leadership from the pathology department. But more importantly, initial reports from Wuhan, from China, said that kidney injury really did not occur in COVID-19 patients. But as the pandemic started moving to Italy, France, and the US, it became very apparent, as this study from Mount Sinai, where they had more than 4,000 patients with COVID-19 that were hospitalized, and about 40% of them ended up getting acute kidney injury, and half of those required dialysis. And if you require dialysis, and if you're on the ventilator mortality was 90%. So you can just imagine the impact if you had kidney injury and you were on a ventilator and you had COVID-19. A lot of them who survived never returned to baseline kidney function. So they have some sort of chronic kidney disease, and it's considered as one of the long COVID syndromes that you may end up with underlying chronic kidney disease. And this is just some of the data you can see, almost 4,000 patients. This was during the first wave from February to May. You can see almost 4,000 had AKI. Half of them required dialysis, and half of them actually ended up dying with COVID-19. And this is just a survival, that if you had AKI and COVID-19, your overall survival, as shown here in the red, is significantly lower compared to if you did not have acute kidney injury. A nice review article that was published late last year just highlights what is the pathophysiology of COVID-related kidney disease. You can see here, the virus enters through this ACE2 protein, and it turns out this ACE2 protein, in addition to the lung, has high abundance in the kidney, in the proximal tubule, and that is the cell type that is highly metabolically active and most vulnerable to ischemic or nephrotoxic insults. And you can see through, cytokine storm, hypovolemia, or medications that these patients receive, potentially direct viral infection, that you may have circulatory collapse, rhabdomyolysis, a coagulation problem within your microvasculature, that either you have prerenal azotemia, tubular injury, myoglobin, CAS nephropathy, thrombotic microangiopathy. Some cases very similar to HIV-associated collapsing nephropathy has been reported, and they call it COVAT, COVID-19 associated collapsing GN. Some case reports of crescentic GN as well as membranous and minimal change have been reported. And this is, I thought, relevant to the pathology audience, and Dr. Rosenblum, Dr. Huma, and colleagues that have been tremendously helpful to our division in terms of our renal biopsy conferences, which is one of our most popular conferences for our trainees. Just shows you the spectrum of kidney pathology that occurs in COVID-19 related kidney disease, collapsing GN, thrombotic microangiopathy, acute tubular injury, oxalate nephropathy, myoglobin nephropathy, crescentic GN, minimal change, membranous, as well as interstitial nephritis, potentially due to medication. So really broad spectrum, and we're just beginning to just scratch the surface in understanding this disease more. If you look at the clinical impact of this, and this was again done through Northwell Hofstra hospitals in New York. So they looked at clinical productivity of nephrologists during the pandemic. So in the purple is the productivity 2019, and this is the x-axis is the week of the year and daily hospital admissions. And you can see in the yellow is what happened during the pandemic. So you can see clearly the hospital shut down and there's only COVID patients. So the number of admissions dropped. And this was by design, just like what we did at UAB. But when you looked at the nephrology consultations, even though the admissions dropped compared to the previous year, there was a huge increase in hospital consultations for nephrology to provide dialysis and other support services, and something very similar to what we observed here. Even though our hospital capacity dropped to 50-60%, our business, so to speak, in terms of workload for our faculty and our fellows was almost double in terms of the nephrology consultations that we saw during this pandemic. We saw the same trend, in December, January, when this occurred during the third time. And this again shows you the dialysis treatment. CRRT refers to continuous renal replacement therapy, huge 3-4-fold increase in renal replacement therapy requirement compared to 2019, during this pandemic. And this was during the first wave in the spring and early summer. So acute kidney injury, earlier it was thought that, in the light green here, you get an insult, it get better, you go home. But more recently, it's been found that acute kidney injury can actually lead to chronic kidney disease. And if you have underlying chronic kidney disease, you're predisposed to worse acute kidney injury. So if you have diabetes and if you have mild chronic kidney disease, you end up getting a cardiac bypass or another major surgery, it's highly likely that you'll get acute kidney injury. And about 10% of patients actually will never recover from that chronic kidney disease and end up with end-stage kidney disease, needing either dialysis or potentially even a transplant down the road. And that's shown in the red here. And this was even pre-COVID that these numbers have borne out. And this is a large study, over 500,000 patients from a group in California, where they looked at patients with GFR that was better than 45 ml. So they had, stage 3A or better in terms of kidney function. And you can see if they did not have AKI, as shown in the blue, not a single or very few ESRD cases that you would expect in the population. But if you had acute kidney injury, the risk of progressive CKD was about 5-fold higher. So huge issue. You have underlying CKD, even mild forms, that it predisposes you to get acute kidney injury. There have been some deep learning approaches using artificial intelligence. And this is a group from Mount Sinai in New York, where they mined electronic health record data from intensive care units in tertiary hospitals and used deep learning algorithms and actually did subphenotyping of acute kidney injury. So not like all acute kidney injury is the same. So they had about 4,000 patients with sepsis AKI, and they found 3 very distinct subphenotypes. And you can see that referred to as phenotype 1, 2, and 3. And what they found when they did this analysis through this figure, you can see in the blue, green, and orange, that these were 3 very distinct subpopulations of patients that were characterized with this artificial intelligence algorithm that these investigators used. More importantly, there was huge differences between these subphenotypes in terms of needing dialysis or mortality. So if you're in the subphenotype 1, very few needed dialysis and relatively few, 20% or so, died. But in the subphenotype 2, this was significantly higher, and subphenotype 3 was much higher. And these were the phenotype that required vasopressors, they had underlying comorbid conditions, and so on. So just based on the electronic medical record, we can actually develop predictive models that if you have a patient coming into the hospital, what phenotype would you come into that you may end up either dying or needing dialysis or not recovering kidney function, just based on the EMR and basic, standardized lab tests that we would do without doing anything fancy. So remarkable ability using these deep learning approaches for clinical prediction of the outcomes for acute kidney injury. Let's talk a little bit of biomarkers, and this is pertinent to lab medicine from pathology, where we work very closely with colleagues in pathology. So a lot of biomarkers have been investigated to make an early diagnosis of acute kidney injury. By the time your creatinine, which is currently, unfortunately, the gold standard, it's too late. It's like after you've had a myocardial infarction and the myocardium is already damaged, that's when your markers would go up. And that's what creatinine is for acute kidney injury. And it's too late to say, let's do an intervention and reverse that acute kidney injury. By the time the creatinine goes up, you've already got full-blown acute kidney injury, and you'll need, either dialysis or potentially down the road, a transplant. So there's been really vigorous research in biomarkers, and you've heard of NGAL, KIM1, various other markers. A new biomarker that has shown a lot of promise. And some of the biomarkers are also nice because they tell you the site of injury in the kidney. And this is a picture of a nephron. Whether you have damage to the glomerulus, then you'll spill more protein in the urine. If you have injury to the proximal tubule, and these are markers that are specific to the proximal tubule, or some to the distal tubule, the collecting duct, the loop of Henle. So these biomarkers can actually predict the type of injury, the cause of injury, and what region within the kidney you suspect the damage to occur, and thereby these biomarkers. And some of these biomarkers actually go up much earlier, within hours actually, before the creatinine would go up, and are usually point of care testing efforts are ongoing So you could test at the bedside with a dipstick and say, hey, you have acute kidney injury and your creatinine may still be normal at that time. A new study published last year looking at this soluble urokinase receptor and acute kidney injury. And what this is, it's a circulating form of a glycosyl PI3 anchored 3-domain membrane protein, very low levels normally. And these are mainly from endothelial cells and the podocytes within the kidney. They're very strongly predictive of progressive decline in kidney function in proteinuric models. And in this study that was featured with an editorial in the New England Journal last year, risk prediction for acute kidney injury, super important, now super easy. And that's just a twist to soluble urokinase receptor. And what they found in this work, here's the odds ratio for acute kidney injury. So these are high-risk patients who are undergoing a cardiac catheterization, so they get a load of contrast dye. And contrast dye causes high risk for acute kidney injury. And based on any of these three models, unadjusted model or adjusted model, or if you remove all the covariates, higher the level of SUPAR, you can see here as the quartile 4, you had a higher odds ratio of developing acute kidney injury in this setting. And a large number of patients, almost 4,000 patients in this study from the New England Journal of Medicine. So a lot of work in this area to try and find better biomarkers than creatinine. And clearly we would need help with lab medicine in incorporating those biomarkers once they are FDA approved and so on. There are some newer angiogenesis related biomarkers, for example, VEGF, VEGF-R1, as well as PGF. And you can see VEGF-R1, which is an anti-angiogenic biomarker, is increased odds ratio. And these VEGF and PGF actually has decreased levels actually predict worse outcomes in this setting. I'll talk a little bit about pathogenesis of acute kidney injury, and this is really multifactorial. There are a lot of different mechanisms, but I'll really highlight mitochondria and immune mechanisms, given the interests of your group in mitochondria. So this is an elegant paper looking at PGC1 alpha, which is a master regulator of mitochondrial biogenesis, and how this was linked to oxidative metabolism and protection within the kidney. And what these investigators actually from Beth Israel in Boston found that PGC1 alpha was linked to metabolism of NAD. And when you had acute kidney injury, NAD levels were actually depleted. And if you were able to supplement NAD in animal models and in humans, and I'll show you some of the data, you could actually reverse acute kidney injury by reversing the electron transport changes and lactic acid generation from the mitochondria, affecting fatty acid oxidation as well as glycolysis. So essentially, they showed that this PGC1 alpha protects against regulating NAD biosynthesis. And if you treated, and this was a paper that they used where they treated with precursors of NAD in acute kidney injury in humans, that was published in Nature Medicine, but you can buy NAD, which is essentially niacinamide, vitamin B3. You can buy this as a nutraceutical from a grocery store. So they gave 1 gram or 3 grams of this medication to cardiac surgery patients. Before they underwent cardiac surgery, they had high risk for acute kidney injury. And you can see, and they started at day -1 and continued it for day 0 as well as day 1. And then they followed up these patients. And you can see in red, the patients that got placebo had a mild increase in creatinine, showing acute kidney injury. And the ones that got either 1 gram or 3 grams of NAD, actually niacinamide, actually were protected. They have very exciting data with NAD now in a large population of COVID-19 patients to show that administration of this nutraceutical actually reduced the incidence of acute kidney injury in the setting of COVID-19. And through our O'Brien Center, we're actually doing some metabolomics for their group, looking at changes in urine with and without NAD in their patients with acute kidney injury. In terms of immune mechanisms, a lot of focus on these two cell types, macrophages as well as dendritic cells. And there's a lot of overlap between the markers we use for macrophages or dendritic cells within the kidney, and that overlaps between mice as well as humans. If you look at the kidney itself, there is a massive network of mononuclear phagocytes, and shown here is a low magnification of a mouse that all the macrophages are labeled green through a CX3 CR1 receptor fractalkine and labeled with GFP. And you can see here on a higher power, in the red are all the tubules, and in the green are these macrophages, or previously thought to be dendritic cells, that are scattered along the kidney interstitium. And they have these dendrites or projections that extend into the tubules. They're very intimately associated with the proximal tubules. And in some work that we have ongoing in collaboration with Dr. Jim George, we have actually found that within the kidney, there are two populations of these mononuclear phagocytes, shown here as R1 and R2. These R1 cells are the infiltrating cells that come into the kidney following injury very early in hours. And there are resident macrophages called R2 macrophages, shown here. And if you look at these cells, and if you do single cell RNA sequencing, so in mice, rats, pigs, or even in humans, you can take the kidney, isolate these cells, FACS sort them, isolate these leukocytes by CD45, and then do single cell analysis. These cell types are not just one single cell type. They actually are multiple cell types, and shown here is just a plot where you can see in mice, in rats, in pigs, as well as in humans, these are actually conserved gene expression signatures across these species. So you can see these infiltrating macrophage population in blue, NK cells, resident macrophages in red, some neutrophils, as well as a few dendritic cells. So these cells actually are critically involved in processes like phagocytosis, efferocytosis, immune cell clearance, and so on. That's a subject of studies that are ongoing in our lab. And another group actually confirmed some of our findings that these macrophages or dendritic cells are actually distinct subtypes. It's not just one macrophage. There are many different cell types. They're actually spatially distributed within the kidney, and they have distinct function in terms of their anti-inflammatory or pro-inflammatory properties. It's not just the traditional M1 or M2, but actually may extend beyond those two predominant subtypes. And there was an editorial featuring that actually what was thought to be dendritic cells actually were precursor cells to these macrophages, and at least shown here are 4 different types of these monocyte phagocytic cell lines with very specific markers, very specific functions, at least within the kidney. And these authors used sophisticated genetic cell lineage tracing to identify the function of these cell types within the kidney. And it's known in the past that if you deplete macrophages early in acute kidney injury, actually it decreases injury. But if you deplete macrophages after acute kidney injury, it actually delays recovery. So these depletion methods are very generic, based on chemical methods using a liposomal clodronate or diphtheria toxin and so on. So it kills essentially all the macrophages, both the good and the bad macrophages. So we have a lot to learn in terms of macrophages and acute kidney injury. And this research is just coming online, in just the last few years. What about progression of acute kidney injury to chronic kidney disease? And how does this happen? What's the mechanism? And it turns out very similar mechanisms occur in the lung and other organ systems where you have an acute insult, and that predisposes you to long-term scarring, fibrosis, and so on. So very elegant studies, published in your journal, the American Journal of Pathology, again, using fate tracing, actually found that it was not the tubular epithelial cells that were precursors to myofibroblast and cause fibrosis, but actually were pericytes. So pericytes, as you know, are cells that wrap around the blood vessel. They kind of support the vasculature. But these pericytes actually profoundly proliferate after acute kidney injury. You can see here the normal kidney, these pericytes, are close to the blood vessel. But once you have acute kidney injury, there's a rapid growth of these myofibroblasts that lay down matrix and fibrosis, But the precursor cell for these myofibroblasts are actually pericytes. So these pericytes start proliferating and go into the interstitium, become myofibroblasts, and through several, cytokine, chemokine like TGF-beta and others, and lay down fibrosis. And really shows that this could be a cell type that could be a target for intervention to block fibrosis following acute kidney injury. Some elegant work from Indiana University, from Pierre Dagger, look at sepsis. Sepsis is one of the common underlying features in patients in the intensive care unit that get acute kidney injury. So very nice work that they did. They looked at translation of proteins within the kidney following acute kidney injury in sepsis. You can see at 0 hours, so each of these red dots reference a protein that is being translated within the kidney. So a lot of proteins at 0 hours, 1 hour, and 4 hours, and 28 hours. But you can see here in the top, in the 16-hour time point, there is a significant shutdown of protein translation within the kidney in these models of sepsis. And what they found was there is this protein that is involved in the antiviral response, within the body, referring to elongation factor IF2 alpha, that was critical in this translational shutdown of proteins. And if you block this through this compound, ISRI-B, you could actually prevent sepsis-induced acute kidney injury in animal models. And the pathways involved included in ATF4 stress and antiviral response, autophagy, and other responses as well. So really novel studies that were published in the JCI a few years ago. Let's refer a little bit to treatment strategies for acute kidney injury. There have been a lot of clinical studies that have been done in animal models. Unfortunately, very good results in animal models, but when they took them to humans, none of these studies really panned out. And the only FDA-approved treatment we have today for acute kidney injury is dialysis. And as we know, dialysis is not a treatment. It's a supportive modality until the kidney kind of wakes up and starts functioning on its own. But show you some really novel things that have come out in the last few years. Lactate. We normally think of lactate as something that you measure as lactic acid in the blood. That is actually a bad marker. The higher lactate you have, the worse survival if you have sepsis or organ injury. But nice work, again, that actually if you give lactate, through Ringer's lactate and so on, you can actually protect, and this is CLP, which is a cecal ligation and puncture model of sepsis-associated AKI, that this can actually protect against acute kidney injury. And here's the data in terms of KIM1, which is a biomarker that is significantly decreased. And you can look at blood urea nitrogen as well. Following treatment with lactated Ringers, you can protect against sepsis-induced acute kidney injury. And the mechanism for how lactate protects was beautifully elucidated from this group in San Antonio last year, where they found that lactate actually elicits ER mitochondrial shuttle and regulates metabolism within the cell. And a beautiful editorial that was featured in Molecular Cell, oh my God, essentially, oh, magnesium, that lactate actually drives magnesium metabolism, within the mitochondria through this protein called MRS1. And when you provide lactate, it enters the cell and activates magnesium release through the endoplasmic reticulum. And through this transporter, MRS1 regulates mitochondrial metabolism and the TCA cycle within the mitochondria, and thereby improves function. And the kidney proximal tubule after the heart has the highest number of mitochondria. So it's metabolically very energetic because it has a lot of transport mechanisms. The kidney filters 180 liters of blood and has to absorb all the good stuff and keep it in your body, like glucose, amino acids, and phosphate, and so on, and dumps out all the bad stuff in the urine. So it has a lot of transporters and a lot of energy requiring transporters, therefore high content of mitochondria. And thereby we think that some of the effects of lactate could be through this lactate shuttle between the ER and the mitochondria in acute kidney injury. A lot of exciting work in this field and clinically translatable because we use Ringer's lactate, for example, in patients. Some very exciting what's on the horizon. NIH funded a large program called the Kidney Precision Medicine Project, or KPMP, to really try to understand human kidney disease. I showed you that slide with a lot of animal studies, and none of them were translatable to human studies. So the NIH felt like we really need to focus on human kidney disease. So their goal is to obtain kidney biopsies from humans with both acute kidney injury and chronic kidney disease to create a kidney tissue atlas, very similar to what's been done in the brain, in the lung, as well as this human cell atlas that was developed at the Broad Institute. So we can find disease subgroups to stratify patients, to identify critical cells, pathways, and potentially novel targets for therapies. Individualized treatment development to advance our scientific base and really improve our young investigator pipeline. So what they want to do is really develop therapies for our patients. Clearly animal models have failed to some extent to replicate the human disease phenotypes. And we have limited availability of human kidney biopsy tissues. And I'd like to, mention, we worked very closely with Dr. Frida Rosenblum as part of our O'Brien Center, where she's helped us with cataloging human kidney biopsies from patients with acute kidney injury, as well as acute kidney injury in the transplant setting. And we have a catalog of over 800 biopsies of patients that we have made available to our investigator base to validate findings that may have from their animal models. So hopefully availability of these human tissue will enhance our understanding of human biology in patients with acute kidney injury and chronic kidney disease. So this is really building upon our theme of precision medicine. The nice thing about this is the community is involved. Patients, clinicians, scientists, ethicists are involved. The patients are equitable partners, and they have an active voice in this research program. The culture really promotes the priorities and safeties of the patients because it involves a invasive procedure, getting a biopsy. Hopefully this will address a huge public health problem of kidney disease, and the Kidney Atlas will really be an important advance for a field to focusing on kidney pathology, but more importantly, deep profiling for biology. So I'd like to conclude, clearly hope I've convinced you that AKI and AKI leading to CKD is really a growing threat. The COVID pandemic has highlighted that even more. We do have subphenotypes of AKI. It's not all AKI is one and the same. And that has clinical implications, like I showed you from some of the work from New York. Mitochondria really play a central role in the pathogenesis. So clearly they're a great target for intervention. And we have ongoing work with Dr. Victor Darley-Usmar and his group, who's another integral member of our O'Brien Center and funded grants looking at mitochondria as well as immune mechanisms, focusing on macrophages. A lot of clinical work that's being done at UAB as well in terms of dialysis and continuous renal replacement therapy. Although, when to initiate dialysis is a big question mark. I've not gone into details of those studies, and really we've got a lot of potential in this field for future developments. I'll stop there and really thank you for your attention and happy to take any questions.
Thank you very much. Great talk. We can take some questions. We still have time. So from the audience, either write it down or feel free to break in. I didn't see anything on the chat, but I could be wrong.
So there's one question from Dr. Rajasekaran about AI-based stratification of the 3 subphenotypes. He says, seems they're very distinct in terms of morbidity and mortality. What is the actual difference in the progression of the disease in these subphenotypes? Is it possible that the subgroups might have distinct redox makeup? Absolutely, at least I'm biased because that's my area of research. Nobody's looked at that in particular, but I think looking at, markers for mitochondrial function or, F2 isoprostanes, those sorts of things will really help us shed more light. Those are not routinely done. So this was just based on standard available data from the electronic medical record, but not sophisticated tests, Dr. Rajasekaran. But you bring up a great point.
Suri Varambali is also asking a question. Suri, can you go ahead and?
Oh, okay. Yeah, Dr. Agarwal, I was wondering, you talked a lot about kidney injury due to SARS-CoV-2. I was wondering, is anybody looked if it is located or infecting kidney cells, or it is the secondary effects?
Yeah, so initially that data is still controversial. However, they've done autopsy studies and actually found the viral particles in the proximal tubule. And then, like I mentioned, the proximal tubule actually has very high, after the lung, has the highest levels of ACE2 in the proximal tubule. And if you stain the kidney, it's just unbelievably expressed in the kidney. So they think that the virus gets through the ACE2 receptor can and directly infect the proximal tubule and cause, infection, just like HIV can cause direct infection of the proximal tubule. It's still not confirmed, but they've actually found some studies where they've looked at urine from patients, and they can actually isolate proximal tubule cells in the urine as they are damaged and released. They've actually found viral particles, by PCR in the urinary cells as well. So there is some evidence that yes, it may directly infect, the proximal tubule.
Adding on to that, if any studies show that ACE2 inhibitor, commonly used ones, has any sort of effect in curing or preventing or something?
Yeah, that's a great question. So when this first pandemic came out and it was found that ACE2 is the receptor for, SARS-CoV-2, the world just went ballistic because everybody almost is on an ACE inhibitor or an angiotensin receptor blocker, for cardiovascular disease or hypertension or kidney disease. It's almost like it's in the drinking water. And everybody was like, oh, we need to stop these drugs because these patients actually have high levels of ACE2. So if you have high levels of ACE2, you may have more, infection with SARS-CoV-2. But a lot of work was done, and essentially that was debunked, just like the hydroxychloroquine hypothesis. So it was found that no, ACE2 and ARBs are really life-saving. You need to take it for your hypertension or your cardiovascular disease or your, a stroke or, your kidney disease. So please do not stop your ACE or ARB in that setting. And clearly it's been found it does not have an effect on SARS-CoV-2 per se. However, antagonizing ACE2 directly, so if you're taking an ACE inhibitor or ARB, you have high ACE2 levels, but antagonizing ACE2 actually may have some protective effects within the kidney. We're doing some work with Steve Rowe, looking at the ferret model as well as the Syrian hamster model, along those lines. Those are still, I think, to come. So,
thank you.
All right. Next question is from Dr. Adam Wendy, saying, great talk. I have a question about PGC1 alpha effect. What is the exact question, Adam?
Yep. Yeah, I just was getting my name in the list so I could get asked. So great talk. And I'm so happy that we were able to highlight World Kidney Day at Grand Rounds. My question has to do with physiologic stresses that induce PGC1 alpha. So exercise can, fasting can. Are either of those approaches effective at reducing symptoms, and or are they focused on for the timing of dialysis as far as?
So Adam, you bring up a good point. The stress and exercise, those are genetic ways of increasing PGC1 alpha, but it's not organ specific. So you really have to have organ specific, and the work that was done by Samir Parikh and others, they actually knocked out PGC1 alpha selectively in the proximal tubule cell and found that caused worse injury. So you have to selectively target the organ. Agreed that these genetic mechanisms would increase PGC1 alpha overall, but I think you have to have it more targeted approach, to the organ specific area. So.
Thank you.
Next question. Thank you. Next question is from Dr. Ambalavanan. Would use of panel of AKI biomarkers such SUPAR, NGAL, CIS-C, and KIM, etc. in ICU patients help in identification of AKI early enough so one can deploy some therapy based on lactate or mitochondrial directed therapies?
Definitely, Ambal. I think the problem has been, each of these biomarkers was discovered by a different group, and they don't talk to each other, unfortunately. There's a lot of politics involved. So we've been arguing, why don't you develop a dipstick with 10 biomarkers? And that'll really tell us, and FDA would approve it, that would tell us, hey, what's the profile? And that's really been a limitation in our field to translate this. So each company is marketing their own biomarker. Some of them are FDA approved, some are not yet FDA approved. And the more you test these biomarkers, some of them are actually increased even in chronic kidney disease. But I think, we need biomarkers that are better than creatinine. One of the reasons therapies that failed in humans, they've used creatinine as the endpoint. So once the creatinine is up, if you give a therapy, nothing's going to change. We have to use a biomarker where it's increased, and then you give the therapy, and then you would see a distinct change. So I think clearly having a panel, as you suggest, and then having an intervention would be a clear advance. And I know people are now beginning to do that. We don't have any data as of yet, though.
Our next question is from Dr. Manny. Since animal models are not ideal, what are the model options to study the transition from AKI to CKD?
So just like, all of us use animal models for our research, and, animal models are not, imperfect, agreed. Because, we use the same strain, the same species, and so on. But I think they're indispensable. And we actually have published on several models of AKI to CKD where we can cause severe ischemia in the kidney. And then at 4 weeks or 8 weeks, these animals develop significant chronic kidney disease. There's a chemical called aristolochic acid, which is an active ingredient in the Chinese herb. A lot of folks in China and the Balkan area use Chinese herb as a weight loss medication. So aristolochic acid is very high content in these Chinese herbs. And a lot of these people develop chronic kidney disease down the road over years of taking this weight loss medication. So this aristolochic acid is a great model. You give 5 injections, and within 4 weeks, your kidney function is under 25%. And that's another great model of chronic kidney disease that we utilize in our lab, which is due to acute kidney injury, and then you end up with chronic kidney disease. Another model is using cisplatin. Cisplatin is a chemotherapy drug that is used for solid cancers, testicle cancer, ovarian cancers, and so on. Lance Armstrong had testicular cancer. He survived because of cisplatin. But a third of the patients that get cisplatin, unfortunately, get kidney failure, acute kidney failure, and some get chronic kidney failure. So if you give repeated dose of cisplatin, just like patients, multiple cycles, you can end up with chronic kidney disease. So we have an animal model, describing that as well, that we published on models of AKI to CKD.
The AA also causes upper tract urothelial cancer, as you know, and that's an epidemic because of these herbs. We'll finish with Dr. Altoum question: any racial geographic differences and susceptibility to acute tubular injury?
Isam, that's a great question. It's really not been looked at. More recently in the COVID pandemic, we have looked at our data at UAB as part of a global registry that we are developing for COVID-related AKI. And the differences are huge. If you are African American, and this study we're doing with UCSD, so UCSD has a predominant Hispanic population, and we have a predominant African American population. And it is striking to see that if you have COVID and if you are African American, the risk of you getting AKI and dying is almost 5-fold higher. And the same is true for Hispanics. There may be genetic predeterminants, as you know, the APOL1 gene, which protects African Americans from sleeping sickness in Africa. But those mutations actually render you more susceptible to kidney disease once you are in different populations, Europe or in the US. And that actually also correlates with worse acute tubular injury in our setting.
I know Dr. Davis has a comment. Can you go ahead, Greg?
I will. I was just going to say, you had mentioned at the beginning of your talk, Anupam, that death findings from autopsy and death certificates were important, but that's surely underrepresented. The kidney disease, just the the death certifiers I know, myself included, we tend to give precedence to hypertension and don't necessarily look at other end organ disease besides the heart. So if you or some of your colleagues want to try to explore that and see if we can use the medical record to help us determine a more accurate contribution to death, we'd be interested in talking with you.
Well, most certainly, Greg. Thank you for bringing that up. Absolutely, you're so true that this is really underreported. I think a lot of time, cardiovascular disease, heart attack, that gets the press and gets on the death certificate as well. But a lot of issues with acute kidney injury, you die from hyperkalemia or acidosis and so on, which is not properly documented in the electronic medical record. So you're absolutely right. So I think we need to do a better job with that. So, and the data I showed you is I think underreported, because that's from Medicare data. So it's absolutely underreported. You're very right. I'd love to talk to you more about it. So
okay.
Anupam, I have more of a curiosity. So how did the relationship, the O'Brien research between us and UCSD came about?
So when we first were doing this, George, in 2007, when we first applied, it's a P30, so it's a resource for other investigators to use. So we looked at our strengths. So we have strong preclinical strength at UAB. And to be honest with you, this O'Brien would not have happened if it wasn't for several key members from your department, George. Victor Darliusmar, Frida Rosenblum, several others that are key leaders. We have more people outside of our division that are members of the O'Brien. So we had strong preclinical strength, biomarkers, bioanalytical, mitochondria. We didn't have a strong clinical program here, George, in terms of research. And I knew Ravi Mehta at UCSD. He is a powerhouse, for clinical research in acute kidney injury. So that's how we went to Ravi and say, hey, Ravi, can we partner? You can have the clinical core and we'll have the other cores at UAB. So when the first time we submitted, we narrowly missed funding in 2007. They said, how can you work? You guys are 2,000 miles apart. And then we worked together subsequently, and every renewal, I'm proud to say that our team has gotten the best score in the study section. And we're one of 8, in the country. And now, I'm not trying to be arrogant, but people say, the O'Brien Center to emulate is the UAB UCSD O'Brien Center. And it's really a testament to all the faculty that are leaders. And really, we've got folks from pathology, anesthesia, pharmacology, surgery, that are really critical members and leaders of our O'Brien Center. So, and it's been fun. It's been fun for all the trainees to have that exposure as well. So, and it's nice to visit San Diego every year,
Exactly. Not virtually though.
Yeah.
Thank you very much. We're proud of your membership in our department. As
no, I'm honored. Thank you.
Dr. Agarwal is a member of the pathology department too, and thank you for engaging all our junior and not so junior faculty like Victor in your research. So it's been a fascinating, instructive talk. Thank you very much.
Thank you all. Appreciate it.
Bye. Thank you, Anupam.
Thanks.
It was great. It was really great. Thank you.